Assalamu alaikum. Is my voice clear or not?
Alaikum assalam, it's clear.
Okay. Welcome everyone in our interactive sessions. Sorry for previous long time without interactive sessions. Hi Anwar, Rez, Rupain, Walid, Dr. Khan. Okay, let's start. Okay, someone chatting me. Marhab.
لا سلامة دكتور خالد ويلكم باك.
الله يسلمك يا اهلا وسهلا.
يعطيك العافية.
Of course, this is the second interactive session in diabetes because the first one is hypoglycemia, which is presented, I think, since 3 months or more. So this is, we will discuss the most important guidelines and of course, diabetes guidelines. There are a lot of guidelines about diabetes. The most important one is published by JBDS and a nice guideline. So let's start. This is a very famous work published by Sir William Osler. Doctor is a student till his death. When he fails to be a student, he dies. So we must learn every day. These guidelines I prepared since previous examination, and a lot of members these guidelines them. Okay, I will mute someone. Dr. Robin. Okay. Of course, in this interactive session, we missed a lot of our colleagues. Mahmoud Izzat, one of the famous endocrinologists in Egypt, and he passed SCE and European board in the previous year. Dr. Khalid, Dr. Ibrahim Al-Ali, and Dr. Sufyan, and Dr. Osama, Ahmed Mustafa, Abdelaziz, Dr. Rupan Khan, one of very active members in this interactive sessions. And also we missed Nayera, Dr. Rana, and of course, Dr. Gupta and Samar, Yasmin, and Asma, and Amal, and Nancy, and a lot of our members, Shaud Hori. And of course, these guidelines, I prepared 1 week before the previous exam. Actually, I write, this is the most important subjects to revise before 1 week before the exam. At least before the exam, you must revise exam lab. This is one of the most important resources for the exam. Actually, a lot of the questions is picked from exam lab, and this is available already online, and everyone can download it as a PDF. And the next one, Best of 5 or a tool book. This is another very important book. Just revise it before the exam, 1 week before the exam. And also there are about 150 questions in the website published by SCE and European Board. And I already prepared at least 3 previous year examination. Just you want to revise them, and of course the guidelines. And if you write specific notes about from the Oxford handbook, your own notes, you must revise it in the days before the exam. But nowadays we have 5 months before the exam, so you must revise a lot of times the most important reference Oxford handbook of endocrinology and diabetes, the 3rd edition, and also the most important guidelines. You must revise it a lot of times, and inshallah today we will discuss the most important guidelines in the diabetes. the most, of course, diabetes topics resemble about 1/3 of the final exam. It contains, I will show this one, because diabetes in the final exam, it contains 68 questions from 200 questions. So it is about 34% of the questions distributed upon three main topics of diabetes: diabetes diagnosis and management, and another one for complications of diabetes, and the third one, diabetes emergencies. So you need to revise diabetes a lot of times, because if you failed in diabetes chapter, I did not think you will pass the exam. Actually, try to revise diabetes a lot of time. The guidelines, the most important guidelines published by Joint British Diabetes Society in Patient Care, or JBDS, one of them is DKE. And of course, DKE management is very important and critical. Of course, the most, let's try to simplify this guideline. The mortality rate recently is less than 1%. Mortality rate, but with hyperosmolar hyperglycemic state, the mortality is more than 20%. So in DKA, mortality less than 1%. In of course, this is in most of countries. The diagnosis of DKA depends upon three criteria. The first one is ketonemia. Ketonemia means the ketone body in the blood is more than or equal to 3 millimole. More than 3 millimole, or significant ketonuria, which means ketonuria plus 2 or more by Debstag. This is one criteria for diagnosis of DKA. Another criteria, blood glucose is more than 11 millimole or known to be diabetic. The third one is bicarb is less than 15, or venous pH is less than 7.3. This is the diagnostic criteria for DKA. All criteria must be presented to diagnose your patient as a DKA. We will repeat a lot of data more than one times, because in every guidelines they mention in the beginning of the guidelines a summary of the guidelines, then they go to the details. So we will discuss it in more than one time. The first thing you must know that the measurement of blood ketone V is mandatory. Venous, not arterial pH for pH, and bicarb, not arterial pH. The guidelines recommend the venous pH. The monitoring of ketone body and blood glucose by using bedside meter when available. How to initiate insulin is very important. Sliding scale insulin is not used nowadays. It is fixed rate intravenous insulin infusion, FRII. This is very important. It is weight based. So insulin infusion, fixed rate, not variable rate, fixed rate. And of course, venous blood is used for determination of pH and bicarb. We must monitor electrolytes and blood glucose routinely. And in our exam, they asked about serum ketones follow-up, how the frequency of monitoring, every 1 hour, every half an hour, every 2 hours, 3 hours, or 4 hours. And this is a question in our exam. And this is changed from the latest guidelines. They recommend continuation of long-acting basal insulin if the patient is known to be diabetic and already received Levemir or insulin Lantus, for Glargine or Degludec. You must continue the long-acting basal insulin. Pathogenesis of DKA, this is just a hint about the pathogenesis. It is mainly insulin deficiency. Insulin deficiency, either absolute insulin deficiency in type 1 or relative insulin deficiency in some cases of type 2. Insulin deficiency leads to decreased glucose uptake, which lead to hyperglycemia. This is one of pathogenomic criteria of DKA. And of course, glucosuria and osmotic diuresis, and this lead to electrolyte depletion and urinary water loss, which lead to dehydration, which is another pathogenomic features of DKA. And in another arm, insulin deficiency leads to increased lipolysis with increased glycerol and increased free fatty acid. Increased glycerol leads to increased gluconeogenesis in the liver, which lead to hyperglycemia and so on, dehydration and electrolyte depletion. In the another arm, increased free fatty acids leads to increased ketogenesis with increased serum ketone body, which lead to acidosis. This is the criteria of DKA: hyperglycemia and dehydration and acidosis and some electrolyte depletion. A typical deficit in the case of DKA in adults, the water, it is about 100 milli per kg. For example, if in a patient 70 kilogram, water loss is about 7 liter. Sodium deficit, it is about 7 to 10 millimole per kilogram. Chloride is 3 to 5, and potassium is 3 to 5 millimole per kilogram. So in the treatment of DKA, we must replenish the fluid and the sodium, chloride, and the potassium. This is a mandatory for management of DKA. A general management issue in the DKA, we must replace the fluid, potassium, and we must give insulin to resolve acidosis. This is a 3 main line for a treatment of DKA. Bicarb in most cases is not indicated. Phosphate replacement is not indicated. Magnesium replacement is not indicated in most cases. The main aim, the most important one, is fluid replacement, either in DKA or hyperosmolar hyperglycemic state. The main aim for fluid replacement in a case of DKA, restoration of circulatory volume. As we mentioned previously, there is a water deficit about 7 to 10 liter of fluid. It clears the ketone and correction of electrolyte imbalance, hypokalemia and chloride loss. Insulin must be given by fixed rate, not variable rate, not sliding scale. And in some previous exams, they asked about the dosage of fixed rate insulin infusion. It is 0.1 unit per kilogram. 0.1. This is very important. And in a case of hyperosmolar hyperglycemic state, the dose of insulin infusion, if required, 0.05, half of this dose. We must differentiate between DKA and the hyperosmolar hyperglycemic state because the management is different in some situations. So we will mention the difference between them when we speak about it. So the insulin infusion, the dosage of insulin infusion is 0.1 unit per kilogram body weight. And in our exam, asked about during the pregnancy, how we calculate fixed rate intravenous insulin infusion according to the current weight or weight of a pregnant female before getting pregnancy or estimated weight and so on. During the pregnancy, and this is mentioned in the guidelines, we must calculate the intravenous insulin dose according to the current weight. The value of insulin is suppression of ketogenesis. This is the only method to correct the acidosis is insulin. So insulin infusion must not stop for any reason except severe hypoglycemia. Severe hypoglycemia, we can suspend the insulin infusion for just a few minutes, not more, because insulin infusion is the only treatment to suppress ketogenesis. And of course, the insulin infusion, reduction of blood glucose and correction of electrolyte disturbance. This is also very important numbers to memorize. The metabolic treatment targets the blood ketone must be decreased by 0.5 millimole per hour per liter per hour. If anyone has any question, just let me know or a comment.
Excuse me, sir, I have a question here.
Yes.
If the potassium drops during the treatment, let's say he develops hypokalemia, shall we stop
Yes,
insulin?
I will mention it when we speak about the potassium.
Thank you.
So metabolic treatment targets, we must memorize this number. Reduction of blood ketone must be decreased by 0.5 per hour. The venous bicarb must increase by 3 millimole per hour. And the blood glucose must be decreased by 3 millimole per liter per hour. If this value is not decreased or increased by these numbers, we must increase the insulin infusion rate by 1 unit per hour. And this will be discussed later. And of course, the potassium, we want to maintain serum potassium between 4 to 5.5. This is the guidelines because in our previous exams, they asked about the question about a patient who have a serum potassium 5.4. And what should potassium replacement be in this scenario? Maintaining potassium between 4 to 5.5. The intravenous glucose concentration, of course, if the patient blood sugar fall below 14 millimole per liter, we must add a glucose intravenous infusion 10%, not to stop insulin infusion. You should add intravenous infusion of 10% glucose. And the volume infused by glucose must be subtracted from saline infusion given. We give in this scenario glucose intravenous infusion with normal saline, and you can decrease a rate of insulin infusion, not to stop it. This is very essential in clinical practice. Insulin must not be stopped in management of DKA. And also patient consideration is very important. We must identify and treat the precipitating factor. And of course, we must revise the injection technique after stabilization of our patient and check that our patient have already blood glucose equipments. And of course, we must check injection site because this may lead to DKA. And of course, every patient must know a sick day rule. And we must check insulin is effective and not expired. And of course, every patient of type 1 diabetes or type 2 diabetes have a specific number to contact with his physician. And of course, education is one of the mandatory steps in management of diabetes. This is another repeated data. We must measure venous, not arterial pH and bicarb. Blood ketone body ketones meter, if available, it is okay. A fluid to use is crystalloid, not colloid. Of course, in normal saline, 0.9% is the fluid of choice in management of DKE and hyperosmolar hyperglycemic state, both of them normal sodium. Of course, a long-acting insulin analog, it can be continued. The fixed rate insulin, intravenous insulin infusion is the method of choice for administration of insulin. Don't use a bolus dose of insulin. This is a nice guidelines. Of course, in children, this is mandatory, and in adults, in nice guidelines, they didn't recommend a bolus dose of insulin. El bicarb is not recommended routinely except very, very, very minimal cases with pH less than 6.9. This is the only indication to give el bicarb in the case of DKE, and this is not mentioned in the guideline. El phosphate should not be supplemented routinely in a management of DKE. This is very important hence. Why we use the venous measurement of blood gases? Because the main difference between the venous and the arterial pH is just 0.02 to 0.15 pH units. So this is not influence our practice in management. And also the difference between the arterial and venous bicarb is just 1.8 millimole per liter, which is not significant in our management of a case. So use venous ABG. The blood ketone measurement, this is important because we have a lot of ketone body, 3-hydroxybutyrate. This is the pathogenomic for DKA, and another one is ketone body and acetoacetate and acetone. The most specific one is the 3-beta-hydroxybutyrate. This is the most important one. And resolution of DKA depends upon the suppression of ketonemia. So we must know how to when the DKA is resolved by ketone body is less than 0.3. And of course, normal saline with the premixed potassium chloride should be the default solution for a fluid resuscitation in a case of DKA. Normal saline is the fluid of choice. The fixed rate insulin infusion, the fixed rate dose is calculated according to the current weight, and this enables rapid blood ketone clearance. The fixed rate may need to be adjusted in insulin resistant state. If the blood sugar is not decreased every 1 hour by 3 millimole per liter, or bicarb is not increased by 3, or ketone body is not decreased by 0.5, we must increase the serum insulin. Of course, the bolus insulin intravenous infusion is not necessary. The bicarb is not indicated because the harm is more than the benefits. And of course, intravenous bicarbonate can lead to decreases serum potassium, which deteriorate the hypokalemia, which already presented in a case of DKA, and also it increased central or intracellular acidosis, and also it can lead to cardiac heart failure. So intravenous bicarbonate is not recommended. Intravenous phosphate also, they didn't recommend a routine measurement or replacement of phosphate in the case of DKA. However, in the presence of respiratory or skeletal muscle weakness, phosphate measurement and replacement should be considered. This in just small cases. Hypokalemia and hypokalemia, of course, hypokalemia is critical and hyperkalemia is life-threatening condition. So it is very important to manage potassium. Hypoglycemia, if we let the blood glucose fall very rapidly, it may lead to cerebral edema, and this is a common mistake. Severe hypoglycemia is also associated with cardiac arrhythmia, acute brain injury, and death. So if the blood glucose is less than 14 millimole per liter, we must give intravenous 10% glucose alongside a normal saline, and this is very important. Cerebral edema is not common, but it may be presented especially in children, and of course it may be presented if we rapidly correct in hypovolemia. And it mostly occur within a few hours of initiation of a treatment and must be treated by dexamethasone and so on. Pulmonary edema, it may occur in some cases of DKA, especially in the elderly, and of course, especially if there is a cardiac function impairment. How to assess the severity of DKA? This is very important. How to classify DKA as severe DKA? If a blood ketone is over 6, bicarb is less than 5, LPH is less than 7, hypokalemia on admission less than 3.5, Glasgow coma scale is less than 12, oxygen saturation is less than 92, systolic blood pressure is less than 90, pulse more than 100 or below 60, or anion gap is elevated more than 16, and anion gap, we must know how to calculate anion gap. Anion gap, it's just sodium serum sodium plus serum potassium minus chloride plus bicarb. This is very important because a case of DKA is high anion gap metabolic acidosis. Anion gap, if elevated, so it may be a case of DKA. Severe DKA, anion gap is more than 60. So this is a criteria for severity of DKA, and of course in hyperosmolar there another criteria in hyperosmolar hyperglycemic state. The most important one in the hyperosmolar LPH is less than 7.1. This is one of difference. Another one, not hypokalemia alone can classify hyperosmolar hyperglycemic as a severe, but hyperkalemia, if serum potassium is more than 6, it can be classified as severe hyperosmolar hyperglycemic state. And we will discuss it in later. How to manage a case of DKA? At the time 0, we must start the fluid by normal saline. Don't start insulin infusion before the fluid. We must start the fluid immediately. The intravenous insulin infusion must be started after fluid. This is very important. How to monitor the electrolytes. The blood glucose must be monitored hourly, and hourly keto measurement. And after that, every 2 hours we must check for potassium and bicarb. So the blood glucose and ketone body must be checked hourly with at least 2 hourly serum potassium and bicarbonate for the first 6 hours of management of DKA. In our exam, they asked about the frequency of checking serum, I think serum ketone. If a blood pressure initially is, the patient is hypotensive, blood pressure, systolic blood pressure is less than 90 millimeter mercury, we must give fluid rapidly over 10 to 15 minutes. Just we give 1 bottle of normal saline over 10 to 15 minutes. If systolic blood pressure remains below 90, we can give another 500 ml of normal saline. And of course, we must check for other cause of hypotension and seek immediate senior assessment. If a blood pressure is okay, the patient is not hypovolemic, shocked, we give in the first hour 1 liter of normal saline over 1 hour, then 1 liter of normal saline over next 2 hours, then 1 liter of normal saline with potassium over next 2 hours. Every normal saline after the initial 1 hour must be included potassium chloride. And then 1 liter over 4 hours, then 1 liter for 4 hours, then 1 liter for 6 hours. So 1 liter for 1 hour, 1 liter for 2 hours, in the next 2 hours, 2 liters, and then every 4 hours, and then for 6 hours. This is very important, the fluid replacement normal saline. All of them are normal saline. When to give potassium, a case of hypokalemia at the starting, at the initial, if the serum potassium is over 5 to 5.5, we didn't replace the potassium, but you must check renal function, because in some cases there is a renal impairment or dehydration and the serum hyperkalemia due to renal affection. If serum potassium is less than 3.5, we must stop, don't give insulin intravenous infusion, because the intravenous insulin infusion will decrease the serum potassium more and more, because it will shift the extracellular to intracellular and decrease the serum potassium. You must replace severe hypokalemia, and of course you must contact of your senior physician. If serum potassium is 3.5 to 5.5, we must replace by 40 millimole per liter of infusion solution. This is very important because if serum potassium, initial serum potassium is 5.4, we must give 40 millimole per liter serum potassium infusion. And this is a question in our exam. So this is very important. If initial serum potassium is less than 3.5, hold the insulin, correct the hypokalemia. If serum potassium is more than 5.5, don't give intravenous potassium initially. If serum potassium is between 3.5 to 5.5, you must give 40 millimole per liter of potassium replacement. Fixed rate intravenous insulin infusion, it is if a weight is not available, you must estimate 18 kilogram. In a case of a pregnancy, use her present weight, and this is a question. Sorry for this interruption.
عيد لنا من اخر النقطه وقفت عندها دكتور خالد بعد اذنك.
Yes, okay. I think this slide is completed. Okay. Okay, everyone interact with serum potassium.
Yes, Dr. Khalid.
Okay. So how to give fixed rate intravenous insulin infusion? It is weight based. During the pregnancy, we must use present weight, and this is a question in our exam. And a dosage of insulin is 0.1 unit per kilogram per hour. This is another question in one of the previous exams. There is no rule for intravenous insulin infusion. We only give a bolus dose of intramuscular insulin 0.1 if there is a delay in setting of fixed rate intravenous insulin infusion. For example, if we have our patient is collapsing and there is we cannot have only one intravenous access, so we can give intramuscular insulin bolus dose of intramuscular insulin 0.1. And of course, it is very important in this guidelines. If the patient already on Lantus or Levemir or Tresiba, we can continue his basal insulin as it is, and this will actually decrease the rate of insulin infusion. From 1 to 6 hours, we must check for clear of blood ketone and suppress ketogenesis. And this is important numbers. A rate of fall of ketone must be at least 0.5. The bicarb increase by 3, and the blood glucose should fall by 3. And maintaining of serum potassium in normal range, and avoid, of course, hypoglycemia by adding 10% glucose. Measure blood ketone and capillary blood glucose hourly, and this is a question in previous exam. And of course, we must check response to fixed rate intravenous insulin infusion. How to assess the resolution of ketoacidosis, and this is very important. If the blood ketone are not falling by at least 0.5, we must increase the insulin intravenous infusion by 1 unit per hour. If the bicarb is not rising by at least 3, we must increase the insulin infusion by 1. If the blood glucose is not falling by at least 3, we must increase the insulin infusion by 1 unit per hour. And of course, okay. A glucose level is not an accurate indicator for resolution of acidosis in euglycemic ketoacidosis. So a resolution of DKA, how to know it, we will hint about it. If the ketone, this is very important, if the ketone and the glucose are not falling as expected, always check the insulin infusion pump is working, because they may be malfunctioning with the insulin syringe pump. Measure venous blood pH and bicarb and potassium. at 1 hour, 2 hours, and every hour thereafter. Continual fixed rate insulin infusion until this is the resolution of DKA. The ketone body is less than 0.6. The venous pH is over more than 7.3, and our venous bicarb is over 18 millimole. This is very important because the diagnostic criteria of DKA, the ketone body is more than 3, the venous pH is less than 7.3, and the bicarb is less than 15. But the resolution of DKA depends upon the ketone body is less than 0.6, not 3. The venous pH is more than 7.3, and the bicarb is over 18. Of course, don't rely on uric ketone, because our dipstick will measure acetone, which is not basogonomic for DKA. The basogonomic is beta hydroxybutyrate, which is converted to acetoacetate. And in management of DKA, acetoacetate, beta hydroxybutyric acid is converted to acetone, and ketone, urinary acetone will be increased. If glucose fall below, this is repeated data below 14, we must add. Okay. Add dextrose 10%. This is very important because in some questions they asked about the percentage of dextrose. They give an option like, for example, 20% or 50%. The dextrose concentration is 10%. And this is very important in management of DKA, identify and treat precipitating factor. And they here in a newly diagnosed type 1 diabetes, we can should be given basal insulin immediately for a newly diagnosed one during the management of DKA. A resolution of DKA defined as the ketone body is less than 0.6, the venous pH is less than 7.3, and this is very important. Don't use the bicarb as a surrogate at this stage because there is a case of hyperchloremic acidosis, and this is a repeated question in exam. A case of DKA, and after 1 or 2 days, the patient is still acidotic. Why? Because mostly it is a hyperchloremic acidosis, and this is a normal anion gap metabolic acidosis. After 20 to 24 hours, we must transfer to the subcutaneous insulin if the patient is eating and drinking normally, and of course, after resolution of DKA. Subcutaneous insulin is started before an intravenous insulin is discontinued. This is very important. And of course,
yes, Dr. Khalid, sorry to interrupt. Can you go back to the previous slide and explain it once again?
This
like
one?
hyperchloremic acidosis. Yeah.
Yes, hyperchloremic acidosis after resolution of DKA and due to the normal sign which is given to our patient, serum chloride is increased more than normal, and it leads to normal anion gap metabolic acidosis. Acidosis is still present, but if we measure the ketone body, it will be less than 0.6, and bicarb of course will be decreased less than 15. So for resolution of DKA, we must depend mainly upon the pH and the serum ketone, not urinary ketone or bicarbonate. In most cases of DKA, after 1 day, DKA must be resolved. If it is still the patient is acidotic, you must suspect it may be hyperchloremic acidosis. And this is a repeated term in the exam. Of course, it is unusual for DKA not to have resolved by 24 hours with appropriate treatment. And of course, after resolution of DKA, we must start by insulin. How to calculate the total daily dose of insulin for naive patient? It is calculated according to the weight, 0.5 to 0.75 units per kilogram. For example, if we have a patient with 72 kilogram person, the units, the total daily dose of insulin is 36. It is the weight multiplied by 0.5 units per day. It is 36 units per day. half of them must be basal insulin, and half of them must be divided as a prandial insulin, and increase the dose or decrease the basal insulin accordingly, self blood glucose monitoring. And this is the very important table in this guidelines, summarize fluid, potassium, and when to give dextrose, and how to follow your patient. Of course, as we mentioned, normal saline is the fluid of choice for replacement. And of course, we must give dextrose if blood glucose is less than 14 millimole per liter. Don't let insulin stop in any case of DKA. And of course, how to replace the potassium. If serum potassium is more than 5.5, no rule for potassium. If less than 3.5, we must correct the hypokalemia and send your review if additional potassium needs to be given. And between 3.5 to 5.5, we must replace by 40 millimole per liter potassium.
So, Dr. Khalid, sorry for interruption.
Yes.
So when potassium is below 3.5, what to do?
Actually, we must stop insulin infusion for a few minutes, not more than 10 or 15 minutes, and correct the hypokalemia. And of course, in this scenario, we must give a high dose. The maximum recommended dose of serum of potassium infusion is 40 millimole per potassium per liter fluid per hour. This is the maximum recommended dose of potassium infusion. If the patient needs another potassium infusion, you must request help from your senior physician. Because as we know, potassium infusion, insulin infusion will decrease extracellular potassium, leads to more hypokalemia. If the serum potassium is 3.5 and you start insulin infusion, the hypokalemia will deteriorate. At least extracellular hypokalemia. As we know, extracellular potassium is about 3% of total body potassium. And this is the last hint from the Oxford Handbook. DKA is usually a failure of self-management. So re-education to prevent the recurrence of DKA. Yes, I am with you.
Yeah. Okay. It's to be noted that potassium chloride should be added from the second liter of normal saline, no?
Yes.
Not from the starting.
Yes.
This
Actually,
is number one.
Yes. And this is, we mentioned it, the first liter of potassium, no potassium added for the first liter over 1 hour. But if the serum potassium is low, we must correct the hypokalemia. Yes, Dr. Mohammed.
Yeah. And yes. And second thing, we use only short acting or rapid acting, and not intermediate or long acting for fixed dose infusion.
Yes, fixed. The only appropriate insulin to be given intravenous is regular or rapid acting insulin analog. NPH is not to be given intravenous. Long acting insulin is not to be given. It is a mistake to be given intravenous. The only insulin to be given intravenous is regular insulin or rapid acting insulin analog. And of course, the benefits of rapid acting insulin analog over regular insulin as intravenous is no difference between of them, but a rapid acting insulin analog is more expensive, at least in our countries. So the recommended intravenous insulin is regular insulin.
Yes. Third thing is to use sodium bicarb for correction of only severe metabolic acidosis when reaching pH below 6.9 or less, and not to give sodium bicarb for fear of cerebral edema.
Yes, we mentioned this actually, and in the guidelines they didn't recommend the intravenous potassium bicarb in all cases, but in other situations, if it's serum pH, this is very important. We didn't rely on the serum bicarb. We only rely on the pH. If the venous pH is less than 6.9, and some authorities recommend if it is less than 6.8, we can give in this scenario only bicarb, and it is recommendation a small dose of bicarb. It is not recommended routinely in the exam. Don't choose any option with bicarb. Bicarb is a wrong answer in the exam.
Yeah. Fourth and the last thing I wanted to add, we should classify diabetic ketoacidotic patient clinically. There is mild, moderate, and severe diabetic ketoacidosis. For mild metabolic acidosis or diabetic ketoacidosis, when to see the patient capable of care of himself, he can take insulin by himself, and there is no disturbed consciousness, and with mild metabolic acidosis, even we can treat as outpatient if he can take his oral and care of himself. And there is a moderate diabetic ketoacidosis if it can be admitted in internal ward, not in ICU or intensive therapeutic unit. Only intensive therapeutic units for pH less than 7.3 or bicarb less than 15, or there is a severe metabolic gap or high ketone bodies in blood, I think more than 3. Only so not always we admit diabetic ketoacidotic patients in ICU or intensive therapeutic unit.
Yes, and this is, we discussed in previously in the first slice. Severe DKA, we mentioned it by some of the criteria, and of course mild DKA some authorities can be managed in the at home actually, mild diabetic ketoacidosis, but not in our localities. Severe DKA must be treated in the ICU as mentioned. If there is blood ketone more than 6, the bicarb is less than 5, the pH is less than 7, this is severe DKA, or hypokalemia or Glasgow coma scale is more than 12, oxygen saturation is hypotensive, the pulse rate is more than 100 or below than 60, or high anion gap. This patient must be treated in the ICU.
Yes, and we should search also for myocardial infarctions for underlying cause, as underlying cause for diabetic ketoacidosis by doing ECG and troponin I, and if so, we can't give normal saline. Instead we can give according to CVB, urine output, blood pressure, and we can use half normal saline instead.
Yes, actually, Dr. Mohammed. Of course, in a case of if the patient is newly diagnosed, type 1 diabetes, newly presented by DKA, so this is a precipitating factor. But if we see a patient with type 2 diabetes and presented by DKA, we must search for underlying etiology. Like underlying etiology in a case of DKA, in type 2 diabetes with the DKA, it is a severe infection, severe pneumonia, cerebral stroke, MI, severe stress condition, which precipitated DKA. So actual, what is the test to be done initially according to your clinical and your case presentation? If the patient is type 1 diabetes and presented by omission of insulin, so this is a precipitating factor, for example, and we didn't need to assess cardiovascular insult except in some situations. Of course, your notes is very helpful, Dr. Mohammed.
Yeah, last thing is, sorry for interrupt you. Diabetic ketoacidosis
your notes, Dr. Mohammed, is very helpful for everyone. It is welcome at any time.
Thank you. Thank you. Last thing, diabetic ketoacidosis can happen in type 1 as well as in type 2. In type 1, yes, it is a normal pathway, but in type 2, we can see it in a rare cases, but we can see it when first discovered type 2 diabetic in adult. It's called latent onset diabetic of adult or LADA. It's a presentation as diabetic ketoacidosis, but if we can measure C-peptide, we can see that there is a amount of C-peptide is still there. it's presented not in a young age. It presented maybe above 30 or 40 age.
Yes, and of course, actually, type 1 diabetes is not unique for children. About a very significant percentage of type 1 presented in the adults, not as LADA, but as type 1 diabetes. For example, Theresa May is type 1 diabetes and diagnosed at the age of more than 50 years, age of 50. So type 1 is diagnosed by antibody and the C-peptide and so on. If the patient is presented, about 1/4 of type 1 is diagnosed, the presentation is by DKA, especially in our countries, and so on. Okay.
So Dr. Khalid, just
Yes.
I'm sorry, I repeat my question again.
Yes.
So if the patient initially does not have hypokalemia, but later develop the hypokalemia, let's say during the treatment, will you stop or will you increase the potassium and continue insulin? Because the guidelines are not clear in this aspect.
I think insulin must be stopped for a short period if the serum potassium is less than 3.5.
Mm-hmm.
And we must correct serum potassium initially and continue insulin intravenous infusion after that. Of course, someone write Lantus, Levemir, insulin, and so on. Okay.
Yeah, excuse me. It should be by some authors to be give routinely potassium chloride with the second bottle or the second liter of normal saline. As a normal pathway of insulin, it will cause hypokalemia. Even with normal potassium, we can give prophylactic potassium chloride 10 milli equivalent from the second for fear of insulin will induce hypokalemia.
Yes, yes.
Yes, Dr. Khalid.
Yes, Dr. Muhammad.
Yeah, we can use from the second as a prophylactic potassium chloride for fear of insulin will induce hypokalemia even with normal level of serum potassium.
Yes, actually, in every case of DKA, there is a potassium deficit, very large volume of potassium loss during the diuresis and during the initial phase. So we must correct the potassium. Actually, in the guidelines from the second hour, we must give the potassium, but according to this value. If it's serum potassium between 0.5 to 5.5, 5.5, we must replace by 40 millimole per liter potassium infusion per liter potassium. This is very important because if we see a case of serum potassium 5.4, we must give a potassium as a replacement because our patient has a potassium deficit.
Yes, and
so
for me,
the main line of treatment. Yes, Dr. Muhammad.
And for me, is a serious pitfall that most of endocrinologists fall in is not to measure potassium initially because of the patient is initially hypokalemic and we start insulin, it will induce severe hypokalemia and respiratory paralysis, even death.
Yes, actually, serum potassium measurement is mandatory. Venous pH and bicarb is mandatory. Hourly glucose measurement is mandatory to go to which pathway dosage of potassium decrease or increase insulin infusion or give 10% dextrose or even to change from normal saline to have tonic saline, which is rarely needed in the case of DKA. This is the last point in management of DKA. DKA is usually a failure of self-management and re-education to prevent the recurrence is mandatory. Another very important guideline published by JBDS is management of hyperosmolar hyperglycemic state. This is just similar in some ways to DKA and different in a lot of ways. The first one, the criteria for diagnosis of hyperosmolar hyperglycemic state is hypovolemia plus marked hyperglycemia, blood sugar is more than 30 millimole per liter without significant hyperketonemia, the blood ketone is less than 3 and the pH usually is more than 7.3 and bicarb is usually more than 15 millimole per liter. And serum osmolarity is very high. It is more than 320 milliosmolar per kilogram. This is the diagnostic criteria for hyperosmolar hyperglycemic state. And of course, the hyperosmolar hyperglycemic state usually presented in the elderly and usually in the elderly with another comorbidities. The patient is usually severely dehydrated and unwell. Blood glucose is very, very high. Osmolarity is very, very high. The mortality in a case of hyperosmolar hyperglycemic state between 15 and 20%. And in some cases reach 50%. This is very important because in some exam asked about the percentage of mortality for DKA or hyperosmolar hyperglycemic state. The goal of treatment of hyperosmolar hyperglycemic state, of course, a normalization of the osmolarity, and this in most cases needs 3 days to normalize it. Replace the fluid and electrolytes, and electrolyte loss in most cases corrected within 3 days, not more, not very rapidly. Normalization of blood glucose, and this is the least one in importance. And of course, the prevention of venous or arterial thrombosis, because so anticoagulant is mandatory in every case of hyperosmolar hyperglycemic state, except if there is a contraindication. And of course, the potential complication and prevent the potential complication like cerebral edema and central pontine myelinosis. And of course, the foot ulceration is common, so we must check the foot of our patient. And this is criteria for diagnosis of severe hyperosmolar hyperglycemic state, and this is must be managed in the ICU. Serum osmolarity is more than 350 milliosmolar per kilogram. Sodium is above 160 millimole per liter. This is different than DKA. This criteria is not present in the DKA. The venous pH is less than 7.1, but in the DKA severe is less than 7. The hypokalemia is less than 3.5. This is the same as the DKA, but here they added hyperkalemia. If the serum potassium is more than 6, this is a severe hyperosmolar. The Glasgow coma scale is the same, is less than 20. The oxygen saturation is the same, less than 92. The systolic blood pressure is the same, is less than 90. The pulse is the same, is over 100 or less than 60. And this is another criteria added for hyperosmolar. The urine output is less than 0.5 milli per kilogram per hour, or serum creatinine is more than 200 micromole. Don't forget micromole per liter. Or hypothermia, or there is a macrovascular event like an MI or a stroke, which is very common in a case of hyperosmolar hyperglycemic state or other serious comorbidities. This is when to treat your patient in ICU or high dependency or level 2 care. A principle of treatment of hyperosmolar is just the most important one, fluid replacement. This is the most important step in management of hyperosmolar hyperglycemic state, normal saline. The fluid loss in hyperosmolar hyperglycemic state is about 10 to 20 liter in a person his weight 100 kilogram. It is a very large liter of fluid must be given for our patient. It is about 10 to 20. Osmolarity is useful, and of course, how to calculate osmolarity is very important. Osmolarity calculated by 2 multiplied by serum sodium, and of course, in our patient, most of them serum sodium is elevated, plus the glucose in millimole per liter, plus urea. If we calculate in our quantities, our units for glucose is milligram per deciliter. We must convert it to millimole by multiplying by 80. So osmolarity, this is another second equation is very important in the exam. How to calculate the osmolarity? Calculated osmolarity calculated by 2 multiplied by serum sodium plus glucose in millimole plus urea. Urea is not elevated, so some authorities can omit urea. And of course, this is very important in every case of hyperosmolar hyperglycemic state. What is the initial step is to give normal saline. The serum sodium is very elevated, give normal saline 0.9. Don't use half tonic saline as initially fluid. The only indication for half tonic saline, if the serum osmolarity is not declining despite adequate positive fluid balance, this is the only indication for half tonic saline. And of course, initially, the initial rise in serum sodium is expected, and also we must continue normal saline. And this, it is not itself an indication for hypotonic saline or fluid. No rule for intravenous insulin infusion initially. The fall in blood glucose should be no more than 5 millimole liter per hour. Low dose intravenous insulin, the initial dose which can be used in some rare situation, initially 0.05 units per kilo, the half initial dose of DKE. Insulin intravenous infusion should only be commenced only once the blood glucose is no longer falling with intravenous fluid, or immediately if there is a significant ketonemia, which means beta hydroxybutyrate is more than 1 or urine ketone is more than +2. This is the only indication to initiate insulin intravenous infusion in a case of hyperosmolar hyperglycemic state. If there is a significant ketonemia, which means the blood ketone is more than 1 or urea ketone is more than +2. When to initiate insulin? If there is no reduction for blood glucose by after initiation of a fluid. And of course, the patient with hyperosmolar hyperglycemic state must encourage to drink as soon as it is safe to do so. We must assess complications like complications of management like fluid overload, cerebral edema, central protein myelinosis, because it may lead to death. Okay. And prophylactic anticoagulant is required in most cases, and of course there is a high risk for foot ulceration, so we must check for foot ulcers. At all time, if the patient is not improving, we must require senior advice. Isotonic versus hypotonic fluid replacement, this is very important in every exam. Normal saline is the principal fluid of choice. We must calculate the serum osmolarity should be undertaken every hour initially, and the rate of fluid replacement is adjusted according to the decrease in the osmolarity. The fluid replacement alone without insulin will lower the blood glucose. But we must shift of water into intracellular fluids. We must know that serum sodium will increase initially, because this is a very important hint. A fall in blood glucose of 5.5 millimole will result in increase in the serum sodium by 2.4. We all of us know that there is a corrected serum sodium, which is calculated by blood glucose. As we know, if the serum glucose is elevated, the serum sodium will be decreased by pseudo, which we know as a pseudo hyponatremia. So serum glucose, serum sodium must be corrected serum sodium according to the serum glucose if elevated. Yes, Dr. Ala?
السلام عليكم.
وعليكم دكتور Ala.
Yes, السلام عليكم دكتور.
وعليكم.
I'd like to ask about the rate of fluid in patient with heart failure. whether it's in DKA or hyperosmolar state.
Actually, in the guideline mentioned that there is a specific situations which need a very fine adjustment for treatment. A patient with DKA, for example, a patient with a chronic renal failure on dialysis, for example, pregnancy, elderly patient with heart failure, and so on. In this situation, actually, the guideline didn't hint about a patient with heart failure, but in our clinical practice, we must manage the fluid replacement very, very slowly according to the CVB. Try to initiate the fluid very slowly according to electrolytes, according to the CVB, according to the another parameters of electrolytes. And in a guideline published in the management of hemodialysis patient, we will discuss it in some details how to manage a DKA in this scenario.
Yes, to emphasize your word, also you should monitor with blood pressure, pulse, urine output, together with if the patient has no central venous line.
Yes, of course. But in especially in the case of hyperosmolar hyperglycemic states, the patient have a lot of comorbidities. For example, the patient is oligouric or anuric and the renal impairment and maybe heart failure. So the mortality in this scenario is very high, and this is the cause why mortality in this scenario is very high, because another comorbidities. But actually in the exam it is easier than this in the exam. Yes, Dr. Ala.
Yes, doctor, thank you.
Okay.
دكتور خالد السلام عليكم.
وعلى سكاته. دكتور حمدي.
ازي حضرتك دكتور خالد؟
اهلا وسهلا.
Actually, doctor, in case of hyperosmolar or DKA in cardiac patient with cardiomyopathy with low ejection fraction or renal failure or regular hemodialysis, actually we consult the cardiology and nephrology at the time to give us the actual and appropriate rate of fluid, and after that we decide. It is not mentioned clear in any textbook what is the rate of infusion of fluid in any cardiac patient or renal patient.
Yes, I am with you, of course. And of course, yes.
Sorry, Dr. Khalid. For any cardiac patient or end-stage renal patients, it is recommended always to 20 to 40 ml per hour. This is as usual, unless the patient is totally anuric or in end-stage renal disease. For those two patients, sometimes we treat without any fluid, except this patient is anuric with end-stage renal disease. But for patient with ejection fraction below 25, we can use up to 40 ml per hour.
Okay, thanks, Dr. Walid. So the initial fluid is recommended as a normal saline in every case of hyperosmolar, and this is a very, in every exam you must see a question like this. A patient with hyperosmolar hyperglycemic state, serum potassium, serum sodium is elevated, and they asked about how to manage initially. One of options is normal saline, another option is half tonic saline, another option is normal saline with intravenous insulin infusion, another option with intravenous infusion with potassium, for example, and so on. The correct answer, no initial intravenous insulin infusion. This is the most important one. Even with hypernatremia, we must start by normal saline. Rising sodium is only concerned if the osmolarity is not declining concurrently, and in this situation, we can add a half tonic saline. A fall of plasma glucose between 4 to 6 millimole is recommended. A rate of fall of plasma sodium should not exceed 10 millimole per liter in the first 1 day. The rate of fall of plasma sodium, this is very important, is not exceed 10 millimole per liter for the first day. The replacement, the aim of a treatment should not replace, it should be to replace approximately one half of estimated fluid within the 12 hours, the first 12 hours, and the remainder in the following 12 hours. A target blood glucose is between 10 to 15 millimole per liter. Complete normalization of electrolytes and osmolarity may take 3 days in a case of hyperosmolar. Insulin dose, if significant ketonemia is present, the beta hydroxybutyrate is more than 1. This is a relative indication to start by insulin from time 0. If significant ketonemia is not present, don't start intravenous insulin infusion. The fluid replacement alone with normal saline will result in falling blood glucose. And of course, if we give insulin and we give a fluid, this may lead to cardiovascular collapse. This is very important. Also, fixed rate intravenous insulin infusion, if indicated, is the method of giving insulin. The dose is 0.05 units per kilogram. A follow for glucose at a rate of up to 5 millimole per liter per hour is ideal, and once the blood glucose has ceased to fall following the initial fluid resuscitation, reassessment of fluid intake and evaluation of renal function must be undertaken. And of course, the potassium acid DKA, of course, don't forget that in the case of hyperosmolar hyperglycemic state, the patient is elderly with a lot of other comorbidities. We must check for a renal failure because hyperkalemia may be the presenting manifestation of renal impairment. So don't forget to check the potassium in every case initially. If serum potassium is more than 5.5, no need for potassium replacement initially. If less than 0.5, this is the same as the DKA senior review. If between 3.5 to 5.5, we need a high dose of potassium infusion, 40 millimole per liter. This is the same as DKA. The anticoagulant is recommended as a prophylactic for every case of the hyperosmolar hyperglycemic state unless contraindicated. The other electrolytes, as in DKA, no evidence of benefits of treatment with phosphate infusion, except if hypophosphatemia persists beyond the acute phase of treatment of hyperosmolar hyperglycemic state, oral or intravenous replacement should be considered. The magnesium also replacement has also not been shown to be beneficial, so should only be considered if the patient is symptomatic or have symptomatic hypocalcemia. In this scenario, we can give magnesium. And of course, the foot protection is very essential because the patient of hyperosmolar may be presented by high risk of pressure ulcer, so we must re-examine the feet in a daily basis. A recovery phase, of course, unlike DKA, of course, we didn't need a rapid too rapid correction may be harmful in the case of hyperosmolar, but we must mobilize our patient as early as possible because it avoid DVT and so on. The intravenous insulin can usually be discontinued once the patient are eating and drinking, and this is different than a DKA because in the case of a DKA we shift to subcutaneous insulin once a DKA is resolved by the ketone body and so on. But in the case of hyperosmolar hyperglycemic state, the intravenous infusion can be discontinued once the patient is eating and drinking. But intravenous fluid may be required for longer period. Most patients should be transferred to subcutaneous insulin. And of course, a regimen of subcutaneous insulin according to your case, premixed or basal bolus, according to the patient case. And this is just two tables summarize the hyperosmolar hyperglycemic state presented in the guidelines, and everyone can print it. It just summarizes in hyperosmolar hyperglycemic state. This is the diagnostic criteria: hypovolemia, marked hyperglycemia without significant hyperketonemia, and osmolarity must be increased, and the venous bicarb is less than 15 or pH is less than 7.3. And of course, a fixed rate intravenous insulin infusion may be required and calculated by this dose in some cases. And of course, here the fluid and the potassium when to be given. And of course, we can give dextrose as this is the last slide in hyperosmolar hyperglycemic state. Actually,
Yes,
in the
Dr. Khalid.
final exam, a lot of question in the DKA and in hyperosmolar hyperglycemic state. Yes.
Yes, yes. If the patient presented with myocardial infarction induced diabetic ketoacidosis, it is recommended to keep the patient on insulin for at least 3 months. If he was on oral anti-diabetic drug, he should take insulin for at least 3 months after infarction before going back to oral hypoglycemic agents.
Actually, Dr. Muhammad, this point we discussed in more debates in the previous year with Dr. Mahmoud Izzat, Dr. Sufyan, Dr. Ibrahim, and a lot of our colleagues. And actually, this is depends upon previous guidelines published 211. But in the recent guidelines, they didn't recommend this. And actually, we didn't review any recent guidelines recommend insulin intravenous for a patient with MI to initiate
Not
insulin for
intravenous, not intravenous,
even
subcutaneous
subcutaneous,
insulin.
even subcutaneous. Most of guidelines nowadays recommend the oral anti-diabetic therapy can be used after transition from the CCU to outdoors. If you have a paper by this, we need to review it because this point we discussed it a lot of times. And actually, I asked Dr. Adel Sayed, one of pioneers in diabetes in Egypt. Dr. Adel Sayed, one of the presidents of MENA region and pioneer in diabetes, and asked about this point, and he accept that we can give oral antidiabetic drug after a few days after MI.
Dr. Khalid?
Yes. Yes, if you want to continue, Dr. Muhammad.
No, thank you. I finished.
Okay.
Thank you.
Thank you, Dr. Muhammad.
Regarding potassium, I found this is an emergency book of endocrinology.
Yes, sir. I don't. Yes. Dr. Walid. Is the voice clear? I didn't hear from Dr. Walid.
Your voice is clear, but Dr. Walid's voice isn't there.
Okay, sorry. Dr. Khalid?
Yes, Dr. Walid.
I found this, I send it for you in privacy in Telegram. If potassium less than 3.3, they said to hold insulin till potassium more than 3.3.
Yes.
And if potassium more than 5.2, don't give potassium, but check serum potassium every 2 hours.
Yes. I want to hint, but in exam, we must follow the guidelines published by NICE and JBDS. And this is very important because, for example, if the serum potassium is 5.4, for example, according to your paper, Dr. Walid don't give potassium. But actually, in our exam, they give a scenario and serum potassium is 5.4. And one of our, the correct option is to give potassium by 40 millimole potassium. And I choose this answer, and Dr. Dr. Mahmoud Izzat select this option. And actually, me and Dr. Mahmoud, our results 100% in the diabetes emergency. So I am sure from this point, we must follow the guideline published by JBDS or NICE guidelines. There are
excuse me, doctor.
Yes?
5.2. This is fellow the American Associated.
Yes, I am with you. There are some of debatable points from NICE and other societies guidelines. We must follow NICE guidelines and JBDS if there is a difference. For example, and we will discuss it in more details in diabetes with pregnancy, metformin is recommended as initial drug in a case of GDM. But in the American or most of other societies, they didn't recommend the metformin as initial syrup. But in the exam, we must follow JBDS and NICE recommendation. Especially in this small scenarios. Yes, Dr. Walid?
A small hint about potassium, but very or too important, is to give potassium chloride with fluid. If we give 400, we can give it on 250 or 400 normal saline over hours, not rapidly.
Yes. And I mentioned that the maximum recommended dose of intravenous potassium is 40 millimole per hour. This is the maximum recommended dose of intravenous
with fluid,
potassium.
not taken alone. With fluid, it should be.
Yes. Actually, serum potassium must be given with the fluid, except if there is a CVB, a central line, because it leads to phlebitis and injury to the peripheral veins.
Thank you very much. Thank you.
This is another very important guidelines, and we mentioned it in the first interactive session with hypoglycemia, but this is very important because at least one or two questions from the enteral feeding, how to manage diabetes or glycemic management during the enteral feeding, and this is the last guidelines published December 2018. The most important points in these guidelines, we must check capillary blood glucose every 4 to 6 hours. In every case of type 1 diabetes, we must continue basal insulin. And we should not omit the insulin. The target blood sugar is very important. It is between 6 to 12 millimole per liter during the enteral feeding. And they recommend to minimize the use of intravenous insulin infusion. Don't use intravenous infusion except in some of specific situations. And also in the guidelines, they recommend use of premixed human insulin for type 2 diabetes at the start and midpoint of the feed. And another option is to give an NPH insulin or isofan insulin at the start, and if necessary at midpoint of feeding. And of course, this is for type 2 diabetes, fully controlled. And they recommend to use a liquid metformin administered via nasogastric tube, the only oral antidiabetic medication which can be used with enteral feeding. This is for poorly type 2 diabetes. A crush or of oral tablet of antidiabetic medication is not recommended. And this algorithm summarizes all the guidelines, and we will check it. This algorithm is very important. Once we diagnose the stroke, we must measure the capillary blood glucose on admission and during the first 24 hours of inpatient. If blood glucose is persistently elevated more than 7, we must determine if our patient is type 1 or type 2 diabetes. If the patient is type 2 diabetes and fully controlled, we have 3 options. Consider metformin liquid via nasogastric tube if blood glucose is more than 12. This is very important when to initiate metformin liquid via nasogastric tube if blood glucose is more than 12. Assess the feed regimen and commence the insulin regimen from choice 3 choice. The first one is premixed insulin at the start and midpoint of the feed. The isofan insulin at the start and midpoint of the feed, or continuation of basal insulin if already prescribed with a bolus dose at start 6-12 hours into the feed as required. There are 3 options. The most important one is premixed insulin can be used at the start and midpoint of the feed. If the patient is type 1 diabetes, we must continue long-acting insulin We give bolus insulin like the third option, type 2, at the start, 6 and 12 hours into the feed as required. And of course, if the patient already in insulin pump, we should stop it. And this is very important in the guideline. Continuous subcutaneous insulin pumps, this should be stopped, and subcutaneous insulin is commenced. How to manage? Of course, the blood glucose must be measured every 4 to 6 hours, and our target is 6 to 12 millimole. If the patient is hyperglycemic, what is the options? Increase the insulin dose by 2 to 4 units. If already in a premixed insulin, we must increase the dose by 2 to 4 units. Or 10 to 20% per dosage adjustment. And of course, we must check for DKA by ketonemia more than 3 or ketonuria plus more than 2. In this situation, we must refer this patient to urgently to management of DKA. If the patient presented by hypoglycemia, blood glucose is less than 4, and this is very important, and we discuss in more details in hypoglycemia interactive session. We have 6 options. The first one is to give 2 glucogel tube, not for use with fine pore nasogastric tube, 1 bottle of glucojuice, 150 to 200 milli of orange juice, or 110 to 140 juice, not 47. 40 juice, not 47. And another option, and this is asked in our exam, to restart feed to rapidly deliver 15 to 20 grams of carbohydrate. And this is asked in our exam. Another option is give intramuscular glucagon. Don't forget, intramuscular, no rule for intravenous glucagon in a nice guidelines for management of hypoglycemia. The only intramuscular glucagon, and the dose is 1 milligram intramuscular glucagon. So there is 6 options for management of hypoglycemia in a case of enteral feeding. The most important one, if you see intramuscular glucagon, this is the correct one, because in the exam they will mention a lot of numbers. For example, 300 milli of orange juice. This is not correct. The correct one is 150 to 200 milli orange juice. This number is very important in the exam. 2 glucogel tube, 1 bottle of glucojuice or orange juice, or 40 juice, not 47, or restart the feeding to rapidly deliver 15 to 20 gram carbohydrate or intramuscular glucagon. And of course, if feed is stopped for longer than 2 hours and insulin has been administered, the risk of hypoglycemia is high. We must commence 10% dextrose. This is very important. And of course, we must continue the feed regimen and review every 2 days. This is just algorithm. It's very important. We must print it in our desk and review it a lot of times, because a lot of exam questions from this table, this figure. If anyone want any question in this guideline?
Not in this, Dr. Khalid. For practical wise, when giving fixed dose infusion, insulin infusion, and the patient weight is 100 and or 60, and the dose is 0.1, so the hourly insulin infusion should be 6 units hourly.
Yes.
But practical wise, follow up hourly glucose when seeing is glucose is down and declines, I should decline also infusion, not keep it on 6. I can lower it to 5 to 4 to 3 according to patient response, and even I can increase it if the response is suboptimal. I'm right for that.
Yes, actually in the guidelines they recommend that hourly blood glucose decline must be between 3 to 5 millimole per liter per hour. if less than this decline of blood glucose, we must increase the fixed rate insulin intravenous infusion by 1 unit. If rapidly decrease of blood glucose, we must decrease by 1 unit, only by 1 unit. We will see what is known as variable rate. Variable rate is not like this. Variable rate, I will show this actually variable rate. This one. This is an example of variable rate. Variable rate, in every hour, we can decrease the blood rate of insulin infusion according to the measured blood glucose. Not decrease by 1 or increase by 1 as a fixed rate. In a fixed rate, we increase by 1 unit or decrease by only 1 unit according to the blood glucose. But in variable rate, we can decrease. For example, if a blood sugar in this hour is this number, the rate is 1.5. And after 1 hour, if blood glucose is more than 20, we shift to 4-hour intravenous infusion. This is a variable rate. In the guidelines, in either DKA or hyperosmolar hyperglycemic state, the only insulin infusion is to be given by fixed rate. And of course, as you mentioned, Dr. Muhammad, we can change the fixed rate insulin intravenous infusion according to the response to the response of blood glucose. Okay. Okay, Dr. Muhammad?
Yes, thank you.
Okay. Another very important guidelines published by NICE, and this is a different from the American guidelines. As we know, this is published in 2015, diabetes in pregnancy. And of course, diabetes in pregnancy contains two categories. One of them is pre-gestational diabetes type 1 or type 2 and get pregnant, or what we know that gestational diabetes, which is hyperglycemia diagnosed during the pregnancy and usually in the second half of pregnancy. A lot of numbers here, and there are some different from American guideline, and we will give just a hint, but in the exam, we must follow this guideline. In the exam, SCE or European board. Preconception planning and care, the target blood sugar preconception, the fasting blood sugar, the same as type 1 diabetes, is between 5 to 7 millimole per liter in fasting. And before meals, the target must be 4 to 7. This is the target of blood sugar preconception for every woman planning to become pregnant. The fasting blood sugar 5 to 7 and the pre-meal 4 to 7. Of course, most of days. How to diagnose the gestational diabetes according to the NICE guidelines? Only 2 value, fasting and 2 hour. Oral glucose tolerance test by 75 gram anhydrous glucose. This is the only, there is no 1 hour, there is no 3 hour values. Only fasting blood sugar is more than 5.6. This is very important or above. A 2 hour is more than 7.8. This is different than either protocol published by American Diabetes Association, the latest guidelines, which contains 3 fasting 1 hour and 2 hour, 1 abnormal value can diagnose the GDM, or if we use 100 gram anhydrous glucose, 1 hour fasting, 1 hour, 2 hour, 3 hour, and we have 2 abnormal value to diagnose GDM. NICE guidelines just till fasting at 2 hour. In some questions they put 1 hour. 1 hour has no rule for diagnosis of GDM. 3 hour has no rule in diagnosis of GDM. And don't forget the fasting plasma glucose 5.6, which equal to 1 by millimole, which equal to 100 milligram per deciliter, and 2 hour 7.8, which equal to 140 milligram per deciliter in our units. This is very important. And of course, a pregnant woman with any form of diabetes, type 1 or type 2 or GDM, a target blood sugar in fasting 5.3, 1 hour 7.8. This is the same as 2 hour diagnostic criteria, and 2 hour is 6.4. It is equal to 120, and this is the same target like American or Endocrine Society, at least for 1 and 2 hours. This is the target. So the target for diabetes during pregnancy fasting 5.3, 1 hour 7.8, 2 hours 6.4, and this number is very important because in some quiz they asked about these numbers. And of course, the intrapartum care, it is very important when to deliver the baby. For type 1 and type 2, the delivery must be between 37 and 38 weeks of pregnancy. This is by elective cesarean, elective vaginal, or cesarean section. Vaginal or cesarean section between 37 to 38. And this is a very important number. But in a case of GDM, this is for type 1 and type 2. For GDM, to give birth no later than 40 weeks. El postnatal, this is very important for gestational. This is for gestational diabetes. Once delivery of the placenta, we must stop all anti-diabetic medication. And of course, we must over lifestyle advice, including weight control, diet, exercise. And we must check fasting plasma glucose fasting, not 2-hour or oral glucose tolerance test or hemoglobin A1C fasting blood glucose at 6 to 13 weeks after birth to exclude diabetes, to diagnose a type of diabetes. If the fasting is not performed after 13 weeks, they recommend fasting plasma glucose or hemoglobin A1C after that. They didn't recommend oral glucose tolerance test for diagnosis. And of course, in any case of GDM, we must annually check for hemoglobin A1C to detect diabetes, development of type 2 diabetes. This is very important because it is a question like this in the exam. How to monitor the blood
Yes,
glucose?
Dr. Khalid.
Yes.
During pregnancy, we can't fully rely on hemoglobin A1C. Instead, we can use fructosamine test instead because it's rapidly glucose measured with albumin with 2 weeks. We can use it every 2 weeks instead of 3 months of hemoglobin A1C fructosamine test.
Yes, actually, in the guidelines, they didn't recommend hemoglobin A1C, and I will go to it after a few slides. And also, fructosamine in the guidelines, they didn't mention a fructosamine by name. They just recommended self-blood glucose monitoring frequency about 6 to 7 times per day, according to the type of diabetes and type of medication. And we will go to it, Dr. Muhammad, after a few minutes, inshallah. And of course, monitoring, this is very important. Monitoring blood glucose and ketone in the preconception, this is very important in the preconception. They recommend every woman who planning for pregnancy to check hemoglobin A1C every month. Because congenital malformation is proportion to the hemoglobin A1C level. If hemoglobin A1C level is more than 10, it is recommended for this lady to not get pregnant. The target blood glucose and hemoglobin A1C in the preconception, this is very important. This is the numbers we mentioned previously. The target blood sugar is fasting 5 to 7 and the pre-meal is 4 to 7. There is no post-meal or post-meal target, just pre-meal. And of course, the recommendation is to keep hemoglobin A1C is less than 6.5 or 48. It is the recommended hemoglobin A1C before conception. And of course, we must reassure a woman that any reduction in hemoglobin A1C level towards the target is likely to reduce the risk of congenital malformation in the baby. And of course, if hemoglobin A1C is more than 10 or 86, we should advise this woman not to get pregnant because the risk of congenital malformation is elevated. And safety of medications for diabetes before and during the pregnancy, Of course, in NICE guidelines, recommended metformin can be used during the pregnancy, and also two rapid-acting insulin analog aspart and Lespro, they recommend them to be used during the pregnancy, but insulin glargine is not recommended because actually it is a category C during the pregnancy. And for a long-acting insulin or basal insulin, isofan insulin or NPH insulin is the first choice for long-acting insulin during the pregnancy. And here they consider continuing the treatment with long-acting insulin analog detemir, which is category B during the pregnancy according to the FDA, and insulin glargine, which is categorized as category C during the pregnancy in the women with diabetes who have established good blood glucose control before a pregnancy. And actually, this is the same recommendation published by Endocrine Society in 2013. They recommend if the patient already in insulin glargine, he can continue insulin glargine during the pregnancy. This is unique for Endocrine Society and also for the NICE guideline. But of course,
yes, this is my first time to hear.
Yeah, this is
my first time to hear that insulin glargine can be used during a pregnancy, only detemir or levemir.
Yes.
This is my first time. And they mentioned that despite insulin glargine has no adverse effect during a pregnancy, but we can't use because of there is no mega data about or surveillance about it.
Yes, actually, don't initiate insulin glargine during the pregnancy. But here they recommend if the patient already on insulin glargine pre-pregnancy and controlled on it, continue it as it is. This is a recommendation by NICE and also by Endocrine Society, actually. And of course, as I mentioned, the previous insulin glargine is category C during the pregnancy. Insulin detemir is safe, is approved, is category B during the pregnancy in all guidelines. So it is safe. But if we initiate insulin, for example, GDM, we must initiate by isofan or MPH insulin or insulin detemir only. This is very important practically. And also, as I mentioned, aspart and Lespro is approved, is safe during the pregnancy, and insulin glargine, which is Bedra, is not approved during the pregnancy. And of course,
we can use sulfonylurea also.
Yes, I will mention it, which is glibenclamide, the only sulfonylurea approved with NICE guidelines. We will go to it, glibenclamide only, not the glimepiride or gliclazide or other sulfonylurea. The only oral anti-diabetic drug which can be used during the pregnancy in special situation is metformin and the glibenclamide, which is published as a glyburide in some countries. Glyburide, it is the same as a glibenclamide. Of course, the ACE inhibitor and ARB must be stopped in any patient planning for any female planning for conception, and if not stopped, once a pregnancy test is positive, it must be stopped. The same for statin. Statin should be discontinued before the pregnancy or as soon as the pregnancy is confirmed. This is for ACE, ARBs, and of course, if the patient already on the ACE or ARBs, we must replace it by another alternative antihypertensive drug to control the blood pressure. This is very important, and we must remember the numbers. Retinal assessment in the preconception period, because we have two topics or two sections: retinal assessment in the preconception and the retinal assessment during the pregnancy, and everyone has a specific numbers. In a preconception, offer retinal assessment to women with diabetes seeking a preconception care at first appointment, unless they have had. Okay. So a retinal assessment preconception must be done in the first appointment, except unless they have been done in the previous 6 months. During the pregnancy, the same, but not 6 months, 3 months. So in a preconception, we must do retinal assessment, except if retinal assessment is done in the previous 6 months. During the pregnancy, once we see pregnant female with diabetes, we must do retinal assessment, except if done within the previous 3 months. This is the difference between preconception and during pregnancy. And of course, then annually, if no diabetic retinopathy is found, but if the patient get pregnant, we must do it, except if it is done in the previous 3 months. And of course, actual rapid optimization of blood control is not advised because it may deteriorate retinopathy. But here, advise a woman with diabetes who are planning to become pregnant to defer rapid optimization of blood glucose until after retinal assessment and treatment have been completed, because it will deteriorate retinopathy. But actually, during the pregnancy, if the patient presented by retinopathy and the blood glucose is elevated and it is pregnant, we must rapidly control the blood sugar. Another very important assessment preconception is renal assessment, and here they recommend to assess renally by serum creat. If serum creat is abnormal more than 120 micromole per liter or more, or urea albumin creatinine ratio is more than 30 milligram per millimole, or GFR is less than 45, we must refer our patient to nephrologist, and this is very important. But during the pregnancy, a referral is not, no GFR during the pregnancy. GFR is not accurate during the pregnancy, so a GFR is not an indication for referral during the pregnancy. This is the two different parameters during the preconception and during the pregnancy. And this is very important. In every exam, there is a question like this: how to assess the risk of gestational diabetes? We must, for everyone, risk of gestational diabetes must be assessed in the booking appointment. Risk of gestational diabetes, body mass index more than 30 kilogram per cubic millimeter, body mass index, not age, body mass index, because in some question asked about age. Age is not a risk factor for development of gestational diabetes in NICE guideline. The previous macrosomic baby, which means the weight more than 4.5, previous gestational diabetes, family history of diabetes, which is first degree relative, not second degree, first degree relative. Minority ethnic family origin with high prevalence of diabetes, this is a risk factor for GDM. Body mass index more than 30, previous macrosomic baby, previous gestational diabetes, family history of diabetes first degree or minority ethnic group. For everyone with a female with this risk factor, we must screen for gestational diabetes. When to screen, this is very important because it is different according to the risk factor. How to screen? They didn't recommend fasting or random or hemoglobin A1C or challenging test or urine analysis. The only recommendation is oral glucose tolerance test by 75 gram anhydrous glucose. This is the only recommendation to screen for GDM. Fasting and 2 hours. And of course, if we detect glucosuria, we must investigate because it may be indication for undiagnosed diabetes during the pregnancy. How to test? By 2 hour 75 gram oral glucose tolerance test. This is the only valid test for diagnosis of GDM during the pregnancy. Gestation, when to do it? Offer women who have previous GDM early self-monitoring blood glucose, and we must do oral glucose tolerance test immediately in the first appointment. And if it is normal by fasting and 2 hours, we must repeat this test at 24 to 28 weeks. This is very important and this is very unique. Yeah. So,
excuse me, Dr. Khalid.
yes?
Can I ask a question here? So, what is the normal values for OGTT during the first trimester? Is it just that usual, or this number that for
they recommend?
Diabetes?
This is the number we diagnose GDM if the fasting more than 5.6, which is equal to 100 milligram per deciliter, 2 hour more than 7.8 milligram per deciliter.
No, I mean in the first trimester, because these are usually for gestational diabetes.
Actually, in the
patient presents in the first trimester.
Actually, in the NICE guidelines, they didn't diagnose gestational diabetes in the second trimester as America or the second of pregnancy. American Diabetes Association diagnosed gestational diabetes in the second half of the
Exactly.
pregnancy.
Yes,
But
after
in
20
the
weeks,
mice,
yes.
in the mice, they diagnose gestational diabetes. Any hyperglycemia at any gestational age is diagnosed as gestational diabetes, except if the patient is known to be diabetic before the pregnancy. So this is the valid number at any gestational age according to the NICE. If fasting
Yes,
blood sugar is more than 5.6, this is a gestational diabetes, and of course 2 hours is more than 7.8. When to investigate or screen for gestational diabetes, if the female is presented with a previous history of gestational diabetes, we must do 2 screening tests at a 2 screening time. The first one immediately, if it is normal, we must rescreen after within 24 to 28. If another risk factor for a body mass index or first degree relative family history or a specific ethnicity, we must screen at the age at 24 to 28 only. So in the scenario, in a lot of questions asked about a pregnant female and the body mass index is elevated, or a previous macrosomic baby, or first degree relative and minor ethnicity, and asked about when to do oral glucose or screening test. When? At 24 to 28. If there is a previous gestational diabetes, we must immediately do oral glucose tolerance test, and if it is normal, we must repeat it in 24 to 28. This is a very important. And of course, as we mentioned, the diagnosis of gestational diabetes according to the NICE, according to the fasting blood sugar 5.6 to our 7.8. And of course, they recommend offer women with a diagnosis of gestational diabetes to review with a joint diabetes and antenatal clinic within 1 week. And here they recommend some of intervention for the diabetes during the pregnancy, explain to the woman, of course, education and teaching and providing of blood glucose monitoring device and how to do self blood glucose monitoring. And of course, this is very important advice about change in diet and exercise at the time of diagnosis. And we must advise the woman with gestational diabetes to take regular exercise at least 30 minutes after a meal, walking for 30 minutes after a meal, except if there is no a contraindication to exercise. And the first step to management of gestational diabetes is a trial of diet and exercise. And this is very important. The exception, if the fasting blood sugar is more than 7, we must treat immediately.
Below 7.
If the fasting blood sugar is more than 7, we must treat immediately. But if the fasting blood sugar is less than 7, we must try diet and exercise. Okay?
Yeah, Dr. Khalid.
Yes.
Yeah. Both are needed. Both are needed, or just we can, if one of them
Anyone, any value, any
was
value.
normal.
No. Or
and we can repeat it, or just once we can rely on. Just we can do it.
One value, one abnormal value. It is a diagnosis for gestational
one
diabetes.
time at a time.
Yes, one value. And another one, once you diagnose gestational diabetes, the second option is lifestyle modification for 1 week. Regular exercise, diet and exercise. But if fasting blood sugar is more than 7, this is an indication for immediate treatment by insulin, actually. We have 3 options in management of GDM or diabetes during the pregnancy: metformin, insulin, and glibenclamide. This is 3 options available in the NICE guidelines. Metformin is indication in all cases of gestational diabetes who does not control on lifestyle for 1 to 2 weeks. Insulin can be used instead of metformin to the woman with gestational diabetes if metformin is a contraindication. In any case of GDM, lifestyle for 1 to 2 weeks, if not reach our targets, as we mentioned, the fasting and 1 and 2 hours, if not reach it, the next option is to give metformin. If the metformin is contraindicated, insulin is an alternative. Offer additional of insulin, this is a very important. Insulin with the metformin if the target is not reached by diet, exercise, and metformin. Immediate treatment with insulin, with or without metformin, if fasting blood sugar is more than 7. This is very important. In any case of GDM, if fasting blood sugar is more than 7, we must start insulin immediately, with or without metformin. And of course, a lifestyle, exercise, diet, exercise must be for every case. Okay? This is a typical question in the exam. They give a scenario of a pregnant female and the fasting blood sugar, for example, is 6.5. How to start the treatment? Lifestyle. If lifestyle modification is failed, the next step is metformin. When to add insulin, if the metformin and the lifestyle not targets is not controlled with the metformin and the lifestyle, then the next option is insulin. When to start with insulin immediately in two situations, the fasting blood sugar is more than 7, and another option if the patient presented by macrosomia or hydramnios. In this scenario, we must start immediately by insulin, even if the fasting blood sugar is between 6 and 6.9. So they recommend consider an immediate treatment with insulin if the fasting blood sugar is less than 7 and the patient presented by macrosomic or hydramnios. Glibenclamide is only allowed for management of gestational diabetes if blood glucose targets are not achieved with metformin, but the patient refused the insulin. This is the only indication for glibenclamide. Another indication, if the metformin is not tolerated, this is an indication for glibenclamide. So glibenclamide is not routinely given in a case of GDM except if the female refuses the insulin therapy or the metformin is not indicated. Glibenclamide, actually, in the American guidelines, glibenclamide and metformin is categorized as category B.
Yes, excuse me, doctor. I think glibenclamide don't give given only in the last gestational weeks, not early.
This is the American recommendation. Actually, glibenclamide is given in the next after the first trimester, but according to the NICE, it can be used in any case of gestational diabetes if the patient is refusing insulin. This is an indication, and actually most of cases, of course, gestational diabetes is hyperglycemia in the second half of pregnancy. Actually, we didn't see a gestational diabetes except in the second half. If we diagnose gestational diabetes in the first half of pregnancy, it mostly pre-gestational diabetes not diagnosed, and the guidelines, even the NICE guidelines, recommend to do hemoglobin A1C to diagnose the pre-gestational diabetes in this scenario. And of course, the metformin is safe according to the females polycystic ovary and get pregnant. A lot of trials mention that the metformin is safe even in the first trimester. But glibenclamide, the safety in the first trimester is not 100% like metformin. And of course, the Endocrine Society also recommend the glibenclamide if the patient refuses insulin therapy. How to monitor the blood glucose during the pregnancy? This is very important because it have a lot of numbers. For type 1 diabetes, during the pregnancy, we must check blood sugar, fasting, pre-meal, 1 hour post-meal, and at bedtime. Fasting, pre-meal, 1 hour post-meal, and at bedtime, 7 times every day. Advise a pregnant woman with type 2 diabetes or gestational diabetes or type 2 on multiple daily dose insulin to check the fasting, pre-meal, 1 hour, and at bedtime, the same. So for type 1 diabetes or type 2 diabetes or gestational diabetes on multiple daily dose, we must check blood sugar 7 times, fasting, pre-meal, 1 hour post-meal, and at bedtime. For type 2 diabetes or gestational diabetes, we must check fasting and 1 hour post-meal. This is fasting and 1 hour post-meal. If the patient already on diet and exercise only, or taking oral therapy, or taking basal insulin therapy only. In this scenario, we check fasting and 1 hour post meal. And this is very important because some question asked about this. When to check blood sugar for a patient already on metformin. This is need 4 times daily fasting and 1 hour post meal. But if the patient in Levemir only, also 4 times fasting and 1 hour post meal. If on the Levemir and bolus insulin, we must check 7 times fasting, pre-meal, 1 hour post meal, and at bedtime. This you must repeat it a lot of times because this is a unique for nice guideline. The target, as we mentioned, for all case of diabetes, we must check fast target fasting 5.3, 1 hour 7.8. This is the diagnostic criteria for the GDM according to the NICE 2 hour, and 2 hour after meal 6.4. This number is actually the same as American Diabetes recommendation, and also they recommend in any patient with receiving insulin glucosamide recommendation to maintain the blood glucose more than 4. More than 4, because if less than 4, it is a hypoglycemia according to this guideline. How to monitor hemoglobin A1C? Here they recommend measuring hemoglobin A1C in all pregnant women with pre-existing diabetes at booking appointment, but the value of this measuring is to determine the level of risk of pregnancy, not to the specific targets and control of blood sugar, to just determine the level risk of pregnancy. And also they recommend the measurement of hemoglobin A1C in the 2nd and 3rd trimester, also for assessment the level of risk for the pregnancy, not to the tight control or not control. And of course, the recommended hemoglobin A1C preconception or during the pregnancy is less than 6.5. And of course, the measurement of hemoglobin A1C in all women with gestational diabetes at time of diagnosis to identify the pre-existing type 2 diabetes. And of course, this is very important, as Dr. Mohammed Noor said, don't use hemoglobin A1C level routinely to assess women's blood glucose control during the pregnancy, especially in the 2nd and 3rd trimester, because in most cases it is not valid. The same recommendation during for patient on dialysis, the hemoglobin A1C is not very accurate. The most accurate method to check the control of blood sugar during the pregnancy and during the dialysis is self-blood glucose monitoring. This is the most accurate method to check the control of blood sugar during the pregnancy or dialysis.
Dr. Khalid, sorry.
Yes, Dr. Walid.
معلش يا دكتور خالد، السنة اللي فاتت جايبين A1C ده تقريبا فيه 4 ولا 5 أسئلة.
Yes.
اللي هو factors affecting A1C, if you have a table or something like that to help.
Yes, inshallah we will discuss it. Yes,
there is an
yes.
echo for sound. There is echo sound with Dr. Walid. Please fix it, please.
Dr. Walid asked in the previous exam, they asked a lot of questions about the factors that affect the hemoglobin A1C accuracy. For example, iron deficiency anemia, it will inflate the hemoglobin A1C or deflate the hemoglobin A1C. And also in a patient with chronic kidney disease, how to assess the control of blood glucose, and a lot of factors actually. And we will try to answer some of this question according to this situation. But we must know that hemoglobin A1C is not routinely used to assist the woman blood control during the pregnancy. The most accurate method is self-blood glucose monitoring, as we mentioned. And of course, as we mentioned, aspart and lispro is rapid-acting insulin analog is recommended over soluble insulin during the pregnancy. Consider their use. And of course, don't offer continuous glucose monitoring routinely during the pregnancy. The only indication to consider is CGM if there is a problematic severe hypoglycemia, unstable blood glucose level, or to gain information about variability. This is the only indication to consider a CGM during the pregnancy. A retinal assessment during the pregnancy is very important. Pregnant women with pre-existing diabetes must do a retinal assessment in the first antenatal clinic unless they have retinal assessment in the previous 3 months. And also we must reassess the retina again at 28 weeks. And of course, if any diabetic retinopathy is present at booking time, we must check it 3 times. One at the first appointment, another one 16 to 12 to 20 weeks, and another one 28. So if the pregnant female presented by diabetic retinopathy, we must check retinal assessment 3 times. If no diabetic retinopathy, we must check it twice during the pregnancy, one in the first antenatal visit and another one again at 28. And of course, diabetic retinopathy should not be considered a contraindication to rapid optimization of blood glucose. And of course, preparative retinopathy or any form of referable retinopathy diagnosed during pregnancy must be referred to ophthalmological review for at least 6 months after the birth of the baby, because retinopathy may be deteriorated after delivery. Diabetic retinopathy should not be considered a contraindication to vaginal birth, and this is very important. Renal assessment during pregnancy is the same. If renal assessment has not been undertaken in the preceding 3 months, we must do creatinine, albumin to creatinine ratio, and total protein excretion if more than 0.5, and refer to nephrologist should be considered. The GFR is not accurate during the pregnancy. Don't calculate the GFR, estimated GFR during the pregnancy. Congenital abnormality, and this is another question from the previous exam. When to do screen for congenital malformation, we must do ultrasound scan for detection of fetal structure abnormality at 20 weeks. At 20 weeks, we must check for structure fetal congenital abnormality. And how to monitor fetal growth and well-being, this must be checked by ultrasound every 4 weeks from 28 to 36 weeks of gestation. And actually, these topics will be discussed when we review the Oxford Handbook of Endocrinology and Diabetes, but this guideline is very important actually, and every data, every number in these guidelines can be a question in the exam. At time and mode of the birth, as we mentioned previously, for type 1 and type 2, the delivery, either vaginal or cesarean section, must be between 37 to 38. And for gestational diabetes, the birth no later than 40 weeks of gestation. How to check blood glucose during delivery, and this will be discussed in more details in the next guidelines. If general anesthesia, we must check blood glucose every 13 minutes. But if spinal anesthesia or normal delivery, we must check blood glucose every 1 hour. So blood glucose control during labor, this is very important, every hour during labor. If general anesthesia, every 13 minutes, and a target blood glucose between 4 to 7 millimole. Intravenous dextrose and insulin infusion should be considered for women with type 1 diabetes from the onset of established labor, and this is variable rate, not fixed rate. We must convert to variable rate intravenous insulin infusion for every woman with type 1 diabetes during labor. Women with gestational diabetes, the most important one is we must offer fasting plasma glucose between 6 to 13 weeks after birth. And of course, every drug must be stopped once the placenta is delivered. And if the patient is not, the fasting blood sugar is not done by this age, we don't do oral glucose tolerance test. We just do fasting blood glucose or hemoglobin A1C after that age. This is the last slide in this guidelines. This guidelines is very important, at least 2 questions from the diabetes with pregnancy guideline. If anyone has any question in this guidelines. Is my voice is clear or not?
Thank you, Dr. Khalid.
Okay. Thank you, Khalid. Your voice is clear. Thank you.
This is the guidelines published by JBDS, and this is very important guidelines about the management of glycemic control in a pregnant woman with diabetes on obstetric ward and delivery units. This most of data we revised it in the previous guidelines. And of course, we must check blood glucose every 1 hour. But if the patient or general anesthesia, we must check every half an hour. And this is very important because it is a question in a previous exam. In any patient with received steroid or steroid-induced hyperglycemia, it mostly needs variable rate insulin intravenous infusion. The target range of blood glucose during delivery is between 4 to 7. All patient with type 1 diabetes and some patient with type 2 diabetes or GDM may require variable rate insulin intravenous infusion during delivery. We can use continual insulin pump, may be chosen to remain during delivery. And of course, we must reduce the rate of variable rate insulin intravenous infusion by 50% once placenta is delivered. This is for type 1 or type 2. But for GDM, we must stop all medication once placenta is delivered. And of course, the insulin dosage may be decreased by 25% less in the at the end of trimester, the third trimester. Of course, as we know, stop all antidiabetic medication at delivery in all patients with GDM. And here they recommended metformin and glibenclamide can be continued or can be used during breastfeeding in a case of type 2 pre-existing type 2 diabetes. This is the only medication can be used during the pregnancy or during breastfeeding. Breastfeeding women should continue to withhold other medications that were stopped after conception, like ARBs or ACE or statin during the breastfeeding is contraindication.
Excuse me, Dr. Khalid.
Yes.
The insulin dosage, I think it should be reduced 25% from the first trimester dose, right? Not the third trimester.
Yes.
Yes.
Actually, we have a lot of data, but this is according to these guidelines, the insulin dose may be decreased by 25 less than the dose needed at the end of the first trimester in the third trimester. But we read a lot of data about the insulin dosage during the pregnancy. For example, in the first trimester, the recommended to starting dose in the 0.7, second trimester 0.8, third trimester 0.9, and 1 unit per kilogram in the full term. But in these guidelines, the dose of insulin is increased or decreased according to the self-blood glucose monitoring actually. So the main factor that influence reduction of dosage of insulin is self-blood glucose monitoring to avoid the hypoglycemia and avoid the hyperglycemia. And this is a section about the glycemic control during steroid administration for promotion of fetal lung maturity. And actually, we will discuss it in more details in the next Friday, inshallah, in the guidelines published by JBDS steroid management. And actually, this is just a protocol. If the patient receives corticosteroid, we can increase the dosage of insulin in the day 1 by 25% and in the day 2 by 40% and so on until stopping of steroid. And this is another method for using of management of hyperglycemia. With the first dose of steroid, start intravenous insulin infusion variable rate. And we gave the bolus, basal insulin needs to be continued as usual. This is important. Mealtime insulin should be stopped even if the patient is eating and drinking because the patient is already on variable rate insulin intravenous infusion. With target blood glucose is between 4 to 7.8, 7.8 not 7. This is during not for patient receiving corticosteroid. And check blood glucose hourly, and of course a normal saline with 5% glucose and potassium chloride is the recommended fluid to use. And the variable rate insulin infusion decrease in most women. We follow this column according to the blood glucose. If we see blood glucose now it is 7.1, we give insulin, variable rate insulin by 1 unit per hour. In the second hour, if the blood glucose is 14, we give increase the units by 2 units per hour, and so on. And here, this is if the blood glucose is not decreased we must shift to this column and so on. If blood glucose is reduced very rapidly, we shift for column below and so on. This is in this slide is simple, and actually in the real exam they didn't ask about this algorithm or how to increase or decrease the dosage of variable rate insulin infusion, but everyone can read it just for his clinical practice. And of course, the insulin pump is not in general. In most cases of insulin pump during the steroid, we increase it by 40%. Increasing the insulin dose may be needed, and if blood glucose is more than 7.8 for 2 consecutive blood glucose, we must shift the insulin pump to variable rate intravenous insulin infusion. During delivery and labor in a patient with metformin or MDI is the same. If blood glucose is less than 4, we must treat hypoglycemia with appropriate food, drink, or commence intravenous 5%. Here they recommend 5% dextrose infusion if nil by mouth. And of course, start variable rate in every case of type 1 diabetes. In case of type 2 or GDM, the variable rate insulin intravenous infusion should be started if 2 abnormal values more than 7. We must start by variable rate insulin intravenous infusion and increase or decrease the dosage of insulin infusion according to the blood glucose monitored every 1 hour. If the woman already on insulin glargine, we must continue the basal insulin, and our target blood glucose 4 to 7. This is for delivery, but with steroid 4 to 7.8. And of course, we must follow following the delivery of placenta, the insulin infusion rate should be decreased by 50% in the type 1 or type 2 diabetes and stopped for GDM. And this is the variable rate which is used during the delivery. And this is just a practical guidance for management of glucose control during labor and delivery for women with insulin pump. Insulin pump, actually in the exam, this is not routinely in the final exam. Insulin pump may be asked about the question about insulin pump, but not during the delivery. And as we mentioned, the postnatal management is very important. How to check, of course, in type 1 or type 2 diabetes. Type 2 can continue glibenclamide or metformin. Type 1 referred to his ordinary insulin, and of course, the dose of insulin must be reduced as pre-pregnancy. And of course, for GDM, all drugs must be stopped. Don't forget that diet for breastfeeding expressing, this is just some hints. Insulin infusion or injection stop when a placenta is delivered. This is for GDM. Pre-existing diabetes who were on oral glucose lowering drug before a pregnancy. Insulin infusion stop. The oral medication can be used. Blood glucose monitoring is essential until the first meal. Subsequent blood glucose monitoring. Treatment regimen when eating normally. Of course, metformin and glibenclamide can be used. This is the repeated slide. And don't forget the contraception and plans for a future pregnancy must be assessed with female. Arrangement for ongoing diabetes care, and fasting plasma glucose is mandatory between 6 to 13 weeks of postnatal. If not done, we can do fasting after that or hemoglobin A1C, and lifestyle modification is mandatory. And don't forget, any female with GDM, a risk of postpartum thyroiditis is elevated, so we must check TSH and anti-TPO in this situation. And this is the last slide in my presentation today. And if anyone has a question about this guidelines, it is welcome. Actually, I already upload the previous presentation I do previous, and also this guidelines I will upload it as a PDF, inshallah, now. And also we have a lot of interactive discussions in the previous year with Dr. Mahmoud Izzat, Dr. Ibrahim, and a lot of our members. And this presentation is already available. So I will and we solve a lot of every question banks. We solve it, and it have a lot of very important questions and data by our colleagues. So I will put the link for it for everyone, because in the next month the opening date for this year exam will be open. So everyone prepare himself from nowadays to enter this exam and pass it, inshallah. If anyone has any question.
Thank you, Dr. Khalid.
Thank you very much, Dr. Khalid.
Inshallah, in the next Friday we will continue guidelines,
Thank
or
you,
we go to the Oxford handbook according to the situation. I will prepare it from today, inshallah. And the next Friday we will I will meet you again. And if anyone has any request about presentation or question bank or program, it is welcome actually.
دكتور خالد بعد اذنك بس محاضرات الثيرويد
انا I already uploaded to the WhatsApp group.
لا حضرتك البيتيوتري.
I bought both thyroid and pituitary. I will show it.
Doctor,
yes.
You can put it in the Telegram because WhatsApp is full. I can't able to join.
خلاص اوكي. I will upload.
يعني هي اللي نزلت يا دكتور خالد البيتيوتري بس.
لا بص pituitary and thyroid. Pituitary and thyroid. I will دكتور حمدي pituitary and thyroid I will I upload both of them.
دكتور خالد.
Yes.
لو سمحت أوصل إن شاء الله ال A1C دي ومعها few words about carbohydrate sorry carb count. Yes, carb count is insulin level.
Okay.
يعني how to carbing count.
Okay, that's okay. I will check it, Dr. Hamdi.
I think you send only pituitary, Dr. Khalid.
No. I am sure.
لا سنة مستنيها ونزلتها لا وتحتها.
كده شوفها.
So I think I sent it to another one. I think Dr. Ruban. I sent it to Dr. Ruban.
Yes, you send a lot of things today too. Yeah.
I sent it, Dr. Ruban. I sent it to you, thyroid.
I did not check it, but I have received some.
Okay, that's okay. I will upload it immediately, inshallah.
If it is in my account, I will forward it.
بتاع الام اس كيو.
What?
في برزنتيشن في البيتيوتري والثيرويد بتاع الام اس كيو برضه وبعد اذن حضرتك لو ينفع تنزلها.
لا انا مش عارفه انهي واحده. انا اصلا حطيت بتوع البيتيوتري كل اللي عملتهم.
لا الناقصه الام اس كيو كانت في محاضره حضرتك عاملها الام اس كيو وبرزنتيشن دي حضرتك ما نزلتهاش.
لا ازاي ثانيه واحده. طيب البيتيوتري اصل already I one of introduction hypopituitarism prolactinoma and incidental wal NFDAs. This is for lecture, and another one by Dr. Ibrahim is already available.
بتاع الدكتور ابراهيم موجود.
فانا بس الاربع محاضرات اللي انا عملتهم انا حطيتهم يعني حطيتهم.
دول حضرتك دول حضرتك موجودين.
بتاعت الاسئله انا ما عاملهاش باوربوينت، كنت بعملها اونلاين من خلال البرنامج على طول.
تمام.
فانا حطيت بتوع الباوربوينت. انا دقيقه واحده انا عملت الثيرويد اوريدي PDF. هو 3 محاضرات بتاع الثيرويد احطهم على طول.
تسلم يا دكتور خير، ربنا يجزيك خير.
يلا نشوفكم على خير كده.
جزاك الله خير يا دكتور خالد.
اشوفكم على خير.
Thank you, Dr. Khalid.
Thank you,
Dr. Khalid.
السلام عليكم.
شكرا.
السلام ورحمة الله وبركاته.